Hello students, this is Dr. Karteek Eswara, Professor, Department of Pediatric and Preventive Dentistry, Vinaga Mission Sankaracharya Dental College, VRMR FDU. Today's topic is pulpectomy. So first we will see the definitions of pulpectomy given by various authors. So first it was 1995, it was given by Mathewson, the complete removal of necrotic pulp tissue from root canals and coronal portion of the primary teeth in order to maintain the tooth in the dental arch. So next definition is given by Fine in 1998. So removal of all pulpal tissue from the coronal and radicular portion of the tooth. Indications of pulpectomy. We will see in general indications, clinical indications and radiographical indications. Coming to the general indications, patient should be in a good oral health with no serious disease. So maximum cooperation of the patients and parents is required. So clinical indications are a tooth previously planned for a pulpotomy that shows uncontrolled pulpal hemorrhage. It is indicated for any primary tooth in absence of its permanent successor. Any deciduous tooth with severe pulpal necrosis provided with no radiographic contraindication. So primary teeth with necrotic pulps and minimum of the root resorption. So pulpless primary teeth with stomas and pulpless primary anterior teeth with speech aesthetics are a factor. Pulpless primary molars holding orthodontic appliances. So coming to the radiographic indications, adequate periodontal and bony support. Next, coming to the contraindications of pulpectomy. So general contraindications are young patient with systemic illness such as congenital ischemic heart disease, leukemia. So children on long-term corticosteroid therapy is also contraindicated. So clinical contraindications are excessive tooth mobility, communication between the roof of the pulp chamber and region of the furcation. So insufficient tooth structure to allow isolation by rubber dam and extracoronal restoration. First we have to know how many canals are there in the, canals and roots are there in each tooth. Coming to the primary anteriors in first maxillary incisor, normally one canal will be there without a bifurcations. In this tooth, the accessory canals are very rare but do occur. So next is mandibular incisors. In this, two canals are seen in less than 10% of the cases. Lateral or accessory canals are very rare in mandibular incisors. Next is maxillary and mandibular canine, a round triangular with the base towards the facial surface. Normally in this one canal is seen. So lateral and accessory canals are very rare. So coming to the primary molars, maxillary first primary molar, in that three roots will be present. So two facial and one palatal root. The palatal root is often in round and longer than two facial roots, that is with 2 to 4 canals, one mesobuccal, one distobuccal, one palatal. So maxillary second primary molar, three roots will be there, two facial and one palatal, 2 to 5 canals will be present. So one mesobuccal, one distobuccal and one palatal. So mandibular first primary molar, two roots will be present, one is mesial and one is distal. Usually 3 canals will be present, one is mesobuccal, one mesolingual and one distal. So mandibular second primary molar, in this 2 roots are there, in one is mesial and one is distal. Usually 3 canals will be present in that particular tooth. One is mesobuccal, mesolingual is one and one is distal. Next, coming to the techniques, there are 2 techniques in pulpectomy. One is one-stage single pulpectomy and multi-visit pulpectomy. Coming to the one-stage single pulpectomy, large carious exposure with frank involvement of the radicular pulp. So inflammation extending beyond the coronal portion of the pulp. So next is multi-visit pulpectomy. In this, infection, abscess or chronic sign exists. So it is a non-vital primary tooth and tooth with necrotic pulp and periapical involvement. Coming to the armamentarium, so most importantly, a topical and local anesthesia is required. So rubber dam kit with cotton roll, mouth mirror, explorer, tweezer and endodontical explorer, handpiece and burrs. So hand instruments like spoon excavator is important, and endo box with endo gauze, H files and K files, paper points and cotton pellets, irrigating solutions. So last is obturating materials are required. Next, coming to the common procedure of the pulpectomy. So we'll see how the procedure of pulpectomy will do. Like first we have to, before starting the procedure, we have to take a preoperative radiograph, must and should, for any kind of treatment, not only pulpectomy, but any kind of treatment, preoperative radiograph is must and should. So after that, we have to give the anesthesia. Next, isolate the tooth with the rubber dam, and after that, removal of caries should be done. After that, deroofing of the pulp chamber and negotiating of the orifices are done. Placing of the files, usually we will keep if 3 canals are present, we will keep different colors, and one is H file and one is K file, or 2 K files and 1 H file, like that we will place in the canals to identify the canals properly in the radiograph. So after that we have to take a diagnostic IOPA radiograph using the file should be in the canal. So after that extirpation of the pulp and irrigation should be done. So now after that drying of the root canals with paper points should be done. So after that you have to select a appropriate size of the spiral root or canal filler or different any instrument, and you have to coat the spiral root canal filler with the slurry of the zinc oxide usinol or any kind of material, obturating material you have selected for the particular pulpectomy procedure. So after that you have to obturate the canals with the any kind of obturating material which is available with you, or usually normal pulpectomy procedures we have to fill with the zinc oxide usinol. Most commonly used was zinc oxide usinol. So after that you have to fill the chamber with the hard consistent of ZY post-obturating restoration can be done. So after that you have to do the or restore the tooth with cystic crown. So after that you have to take a post-operative radiograph. After finishing the post-operative radiograph, that is the final procedure in the your pulpectomy procedure. We will see the different techniques like single visit or one stage single visit pulpectomy and multiple visit pulpectomy. First coming to the one stage single visit pulpectomy, in that you have to do starting is tooth is anesthetized, and after that you have to isolate with rubber dam or any isolation technique. So after that axis cavity opening should be done, and pulp chamber is deroofed. All accessible columnar and radicular pulp tissue is removed, and after that you have to irrigate with the saline. So a diagnostic file radiograph should be taken after that, and the canal should be enlarging them and permit condensation of the root canal filling material inside the canals, and after that flush out of the debris and dentinal shavings with the help of the any irrigating solution. So after that you have to dry the canals with the absorbent points, and after that you have to obturate the tooth completely and seal the coronal and radicular pulp with the obturating material which you have selected. So after that you have to place a final restoration followed by the stainless steel crown. This is the one stage single visit pulpectomy technique. Next is multi visit pulpectomy. This procedure is used for non-vital pulp therapy. So the case selection according to the Patterson and Curzon in 1992, an abscess or any chronic sinus tract, teeth with necrotic pulp or periapical involvement should be selected for this multi-visit pulpectomy technique. So the name suggests that it is multi-visit, that the patient should come for multiple visits. First visit usually we do the axis opening, and second visit you have to do up to the BMP, and final visit you have to proceed with the obturation followed by the stainless steel crown. So in first visit the axis opening we have to see do tooth is anesthetized and isolated. So axis cavity opening should be done, and pulp chamber should be deroofed, and all accessible coronal and radicular pulp tissue is removed using broaches. If anterior tooth is done, you shouldn't use the broaches in the posterior tooth. Why? Because there will be curved roots in the molars. So if you use the broaches, there might be chances of ledge formation, so that your obturation should be, it won't be nice after finishing your pulpectomy. After that you have to place a Comochisol cotton pellet is placed in the chamber, and the temporary restoration should be done. This is the procedure you have to do in the first appointment. Next, coming to the second appointment, mostly you will do the cleaning and shaping. Whatever material you have kept in the first appointment you have to remove first, and after that the appointment should be 5 to 7 days from the first appointment. So remove of the temporary restoration should be done. The file the canals and progressively increasing in diameter. Complete the BMP using, mostly you will use the K files and H files. So K files you will see like there are different colors are there in that. So commonly used was 15. The 15 is white, 20 is yellow, and 25 is red, 30 is blue, and 35 is black. So while doing the biomechanical preparation, you mostly for primary tooth we can go a 40 file, that is black. So in primary tooth, whereas in larger canals, that is maxillary, it is palatal, and mandible is distal. So in that we can go up to 35 file, that is green, whereas in other canals we can do up to 30, max 35 is the last file. So after that irrigate the canals, and you should dry the canals and place the temporary restoration. So next, coming to the third appointment is should be like 5 to 7 days apart, and you have to remove the temporary restoration, irrigate and dry the canals. You have to select one obturating material whichever it is available with you, and or which is suitable, you feel which is suitable for that particular tooth or patient. So first coat the walls with the canals with the water mix of the cement, and then use the thick mix for obturation. So keep adding the fresh mix till no further cement can be incorporated. So after final is seal the pulp chamber with the temporary restoration. So next we will see the different filling materials in primary teeth. So the ideal filling material in the primary teeth given by Costa Cangula. So it should be resorbable, it should be antiseptic, it should be easily inserted, easily removed, It should not be soluble in water, should not discolor the tooth, it should be radio opaque. It should be non-inflammatory and as well as a non-irritating to the underlying permanent tooth or any periapical tissue. So coming to the techniques for the obturation, there are different techniques for obturation. Are there in that the different techniques are endodontic pressure syringe, mechanical syringe, tuberculin syringe, insulin syringe, navi tip, Jiffy's tube, incremental filling technique, lenturospiral technique, double mix technique, and amalgam plugger, paper points by Spedding in 1973. So plugging action with the wet cotton pellet in this, and we can use K file also. So like for example, if you are doing like BMP up to 35 file, you have to select the K file like basic 15 to 20 like white or yellow, and you have to bend the file and you have to use up to the working, you have to bend the up to the working length. Then you can obturate the canal with the using this file technique. So that is the most common technique, and even the plugging action with the wet cotton pellet also will be commonly used. So we will see each technique, right? It's the endodontic pressure technique. It was developed by Greenberg in 1973. In this, a slow withdrawing type motion is used. The needle is withdrawn. So this is the needle. So you can insert inside the canal and withdraw the needle in 3 mm intervals, quarter turn of the screw until the canal is visibly filled with the proper obturating material. So next is tuberculin syringe. It will be same like insulin syringe. So it was given in 1987 by Ireland and Johnson. It is a standard mixture is backloaded into the syringe. So the material is expressed into the canal by slow finger pressure on the plunger until the canal is visibly filled up to the orifice. So insulin syringe technique, it was given or introduced by Priya Nagar. A homogeneous mixture is loaded and a stopper is used at 2 mm short of the apex. So the material is then pressed into the canal, and while doing, the needle is retrieved from the canals towards outside of the tooth. Next is Jiffy tube technique. It was given by Riffison in 1980. In this, standardized mixture is backloaded into the tube. The tube tip was placed in the canal orifice. The material is exposed into the canal with the downward squeezing motion until the orifice appears visibly filled with the selected obturating material. Next is navi tip. So a thin flexible metal tip was introduced by Ultradent in the market to deliver the root canal sealer inside the canals. So this navi tip comes in different length with a rubber stopper. That rubber stopper you can use up to the working length to mark the working length. So for example, your working length is up to 11 mm or 10 mm. So you have to place the rubber stopper at 10 mm or 11 mm so that your obturation should be perfect. There won't be any chance of your obturating material going beyond the apex. Next is lenturospiral, which was given by Koppel in 1970. The lenturospiral is one of the most effective and straightforward techniques for applying the paste using primary tooth canals. So next is incremental filling technique using the endodontic plugger and Pulpectomy of ZOE in increments. It was given by Gold in 1972. An endodontic plugger corresponding to the size of the canal with a rubber stop was used to place the thick mix of zinc oxide eugenol paste inside the canal. So amalgam plugger technique is also there. This was given in 1960 by Nosowitz and King, and premixed mixed syringes are there like these premixed syringes. There are different type of companies or different composition is available like Idocure, like Vitapex, Metapex. These are the premixed syringes is available in the market. Next, coming to the obturating materials. We'll see one by one obturating materials. First is zinc oxide eugenol. First root canal filling material for the primary tooth, which is an anti-inflammatory or analgesic properties there. Mostly used more than 5 years of age. The composition of the zinc oxide eugenol is zinc oxide 42% and stabilitite resin is 27% and bismuth carbonate is 15% and barium sulfate is 15% and sodium borate is 1%. The liquid is coming with the eugenol. Disadvantages of this zinc oxide eugenol obturating material is it's set into the hard mass. There are chances of deflection of succedaneous tooth if the obturating material is gone beyond the apex. After that sets into the hard mass. One more disadvantage is irritating to the periapical tissues, necrosis of the bone and cementum, and longer time to resorb than the tooth root. Next, coming to the calcium hydroxide, which was given in 1930 by Hermann. So mostly this calcium hydroxide is having the antibacterial effect, so which is having with hydroxyl ions and inactivation of enzymes in cytoplasmic membrane. So when in contact to the vital pulp, the inflammatory root resorption is seen. So well tolerated periapically, causing some degree of apical hard tissue deposition. Mainly the calcium hydroxide serves as an intercanal medicament. Next is walk-off paste. It was introduced by walk-off in 1928. So this obturating material is bactericidal. So it resorbs from a periapical area and percussion area by macrophages within 1 to 2 weeks. So mainly this walk-off paste consists of parachlorophenol, camphor and methanol. Next is KRA paste, that is iodoform paste. So it is which is highly resorbable, bactericidal, healthy tissue in growth at apex. Advantages of this KRA paste is this is radiopaque, does not set into the hard mass. Main disadvantages of this KRA paste is rapid resorption from the canals caused voids, which causes the micro leakage. The composition of this KRA paste or iodoform paste is parachlorophenol, which is 2.02%, and camphor is 4.86%, and methanol is 1.20%, and iodoform is 80.80%. Next is endofloss. This obturating material is a resorbable paste. Powder consists of triiodobethane and iodine dibutyl orthocresol 40%, and zinc oxide 56.4%, and calcium hydroxide is 1.07%. Barium sulfate 1.63%. Liquid consists of eugenol and PMCP, that is paramonochlorophenol. This is the composition of the endofloss. Next is Vitapex or Metapex, which is mostly common used, like one is zinc oxyrizolant and most commonly other material we will use is Vitapex, Metapex in case of any abscess tooth. So if there is no abscess or anything like complete roots are there, we will use zinc oxyrizolant commonly. And if there is an abscess or perolis or any furcal radiolucency is there, then if you do the treatment with the multiple visits, we can go with Metapex first, followed by the zinc oxyrizolant after a few weeks. Next, by using calcium hydroxide, there will be an hollow tube effect. That hollow tube effect was given by Goldman and Pearson in 1965. So the hollow tube effect is like intracanal resorption of calcium hydroxide iodoform paste, followed by the there will be stop of disinfection and become a hollow tube due to the loss of the paste inside the canal. After that, we will see the voids in that particular canals. In that particular void, the tissue fluid containing bacteria can fill in that particular space in an unfilled or empty canals. After that, the infection chances are there. From there, the shift of the pH value is acidic, dissolving the root dentin and cementum, irritating the resorptive process. This inflammation is also causes transformation of non-differentiated cells of connective pulp tissue into giant multinuclear cells, which are responsible for this resorption process. So the quality of your root canal filling material should be decided with the uniformity of obturating material, level of the obturating material, and presence of voids. So you can see like the quality of root canal filling will be decided like quality of obturation is like you have to fill the complete root canals. So like for example, if there are 4 roots are there or 3 roots are there, you have to select the obturating material and you have to fill completely up to the apex. So you shouldn't go beyond the apex. If you see any overfilling is there, then your obturation should be there might be chances of failure in your obturation, not immediately, in the future. Thank you for listening.